Christy, could we have you mute your phone, please?
Christy?
Christy.
I don't think I can do
Is our phone muted?
She heard us.
Hello, Christy?
Yes.
Hi
Hi.
there. Could we have you mute your phone, Christy?
Yes.
Okay, thank you. Okay. We'll call this meeting of the Medical Services Board to order. And Judy, if we could start with the roll call, please.
Christy Blakely?
Present.
Patricia Gibbons?
Present.
Brigida Hughes?
Present.
Brenda Lacombe is excused. Paul Malinkovich?
Here.
Amanda Moore is excused. Jenny Riley? Here. Donna Roberts? Mike Stahl?
Here.
Mary Young?
Here.
Great. Thank you. Quick general announcements. The date and location of the next Medical Services Board meeting. The next meeting is scheduled to be held Friday, May 8th, 2015, beginning at 9 a.m. here at 303 East 17th Avenue in the 7th floor conference room. It is a policy of this board and the department to remind everyone in attendance that this facility is private property. The capacity of the meeting room is 80. Please do not block the doors or stand around the edges of the room, and we'd ask everyone to please turn off their cell phones while in the meeting room as they interfere with the recording equipment. With that, we'll jump into approval of the March 13th meeting minutes. I could have a motion.
So I'll move approval of the March 13th meeting minutes.
Second by Christie.
I got a motion and a second for the meetings. All those in favor signify by saying aye.
Aye.
Ms. Blakely?
Aye.
Mary?
Aye.
Thank you. We have approval of the minutes. Before we jump into the rules, we're going to do a legislative update. Zach, if you'd like to kind of come up and give us a quick update of what's happening.
Morning. My name is Zach Linkwitz. I'm the department's legislative liaison, and once again, I appreciate you guys taking me out of order so that I can get back to my friends over at the Capitol. I'm not sure I consider them friends at this point, but it is what it is. So I have a few updates, and if you have any questions about other bills that I didn't cover today, I'm happy to answer those as well. Over the last 2 weeks, the legislature has been busy passing the long bill. This is the bill that funds most of state government, including a large portion of our budget. Most of our priorities went unchanged from the last time that I presented you guys with our budget document. There were some slight modifications to the targeted rate increases, and me and Josh Bach, our budget director, will plan to come back at the next meeting to discuss which things actually were set and done final, signed by the governor at the next meeting. Right now, to go through all that might not be worth it, just because conference committee is still going to happen for long bill. Our House Bill 151186, which is the expansion of the Children with Autism waiver, that passed out of the Senate Health Committee yesterday on a 5-0 vote. It will be headed to Senate Appropriations, but the funding is already included in the long bill, so it shouldn't be much of an issue. It's also a joint budget committee bill, so no issues anticipated with that passage. On Senate Bill 11, this is the spinal cord injury waiver renewal bill that passed out of Senate Health and Appropriations this morning unanimously. So again, I think that one is good to go as well. And then once it's been delayed quite a bit, so it will head to the House after this. But since the appropriation's already in it, at this point in the session, the money's tight because the long bill's already gone through. So if the money's already appropriated in one chamber, going through the second chamber is not so challenging. The last bill that I'll talk about this morning is Senate Bill 228, which is the annual Medicaid rate review bill. I don't know if we've talked about this before, but essentially this is a joint budget committee bill. We had intended this to just be a process the joint budget committee required us to do, but then the joint budget committee decided to put it in a bill just to put it in statute and make it a more formal process. It creates a 5-year rate review cycle, so we'll have to look at each rate at least once every 5 years. So we can look at rates more than once in a 5-year period. This guarantees us the ability to a more consistent approach at looking at our rates than we have in the past. It also creates a 24-member advisory board made up of provider representatives to help the department determine which rates are reviewed in which cycle. And their first meeting will be after September 1st. I think it will be very entertaining to see how that 24 members function. It's passed out of, this morning it passed out of appropriations and it passed out of its Senate Health Committee, I think, last week. So the department is looking forward to a more consistent approach to reviewing our rates. So.
And I think, Zach, is it true, this is Gretchen Hammer, we will be looking to some extent at some of the ways MSB runs itself to help inform how we might approach running this committee, but that when that committee codifies its operations, its bylaws, et cetera, those may come to MSB for a look. Is that correct in the bill, or am I not remembering that process correctly?
I don't think the Medical Services Board is outlined in the bill.
Okay.
It's also been a very long session, so
Yeah.
I think that's up to the department how we operationalize it, but I think that would
Reasonable.
be wise
Yeah.
considering this body tends to function very well. So.
Dr. Link?
Thanks. Who appoints the membership of that review committee?
So the 24 is split into 4 groups, and they're appointed by the leadership of both chambers, the Senate President, the Senate Minority Leader, the Speaker, and the House Minority Leader. And some of the associations with lobbyists have added amendments to the bill so that those associations can help the leadership determine who should represent that particular provider group, because some of the leadership is not as familiar with who should be representing. Think of a provider group. There's it's the gamut.
Mm-hmm.
Questions? Ms. Riley?
Wasn't there a bill about pregnant women or something like that? What happened with that?
Yes, and I apologize. I didn't know if I talked to you about this last time. So the department did have a teen pregnancy and dropout prevention program bill. It would have expanded the program statewide. Right now it's in Mesa, Montrose, and Delta counties. The bill would have allowed general fund to be used for the state share, which was only 10%. 90% is federally funded. The bill was assigned, so it passed to the House, and then it was assigned to Senate Finance, and it died on the party line vote. Family planning bills are tough to get through this session, and I think our friends at CDPHE are also in the same place as we are. Christy had sent me an email earlier asking about the LARC bill, and currently that is still in the House. It will go to the Senate. There's been several amendments in the long bill related to LARC. All of them, the Senate amendments failed to just get that $5 million for LARC funding. The House amendment passed, but then once the conference committee comes back, it's the joint budget committee members and really decide which amendments to take. They'll likely, it's their practice to generally strip off amendments that weren't adopted in both chambers. So I think that bill has an uncertain future.
Zach, there's been conversation about late bill status on that teen pregnancy prevention, dropout retrieval. Is there any new movement there?
I apologize for not catching on to that. So yes, we are trying to get a late bill for the teen pregnancy and dropout prevention program. I think it was assigned to the wrong committee. I think it was more appropriate to have assigned it to Senate Health, and I think we would be more successful in Senate Health. At this point, I'm working with Senator Roberts to determine whether or not her leadership will let her get a late bill, and we also need to ensure that it has the votes to get through the Senate. Otherwise, it's sort of a lot of effort towards nothing. So I think the main challenge for us is getting it through Senate appropriations, even though it has a very small general fund impact, $20,000 for next year, and it saves $600,000 in general fund the following year. It still is assigned to appropriations. That's one more hurdle that we have to pass. So I think if it had gone to Senate Health and it didn't need to go to appropriations and just went to the Senate floor, I don't think we'd have issues, but those committees provide checks and balances to the process.
Well, really appreciate your support on that bill. That program's been highly successful in Mesa and Montrose counties, and would love to see it continue.
Yeah, I mean, if you contact your legislators, particularly your senators, we'd really appreciate it. Any support would be beneficial.
Great, thank you. Other questions? Yeah. All right. Thank you very much. Appreciate that. For the record, Ms. Roberts has joined us. Welcome. Thank you. Jumping into the rules portion, we have one rule on the consent agenda. If there's no reason to pull it, I'd look for the motion for the consent agenda.
I move the final permanent adoption by consent of Document 1, MSB 15-02-11-A, revision to the Health Programs Office Benefits and Operations Division Ambulatory Surgery Center rule concerning a technical correction to the amount, scope, and duration of services, Section 8.570, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
A second.
Got a motion and a second on consent agenda. All those in favor signify by saying aye.
Aye.
Ms. Blakely?
Aye.
Dr. Young?
Aye.
All right, we have final permanent adoption of the consent agenda. Thank you very much. We've got two rules on the slate for final permanent adoption. If I could have a motion for document 2.
I move the final permanent adoption of document 02, MSB 14-02-12A, revision to the medical assistance long-term services and supports rule concerning community transition services, section 8.553.1, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Second.
Got a motion and a second for document 2, and we have Nora Bray and Tim Cortez here to present. Or maybe not Tim. Come up, introduce yourself, and please give us an overview.
Good morning, Mr. President. My name is Nora Bray. I'm the Transitions Administrator for Community Transition Services at the Department of Healthcare Policy and Financing. At our last meeting, we had several stakeholders who voiced concerns about the statement of purpose and the statement of basis and purpose. And since then, we have made some slight revisions to that statement to address their concerns. They were concerned about the statement that said this revision incorporates CCT requirements. CTS is a benefit of the HCBS EBD waiver. It's also a demonstration service of Colorado Choice Transitions. Stakeholders were concerned that that statement created confusion in that the revision would therefore require CCT requirements for all CTS clients, and that was not the case. So we removed that statement. There was also concerns that it was not clear enough that CTS would continue to be a benefit of the EBD waiver. And so we added the statement, CTS will continue to be a benefit of the HCBS EBD waiver to the statement of basis and purpose. The stakeholders have communicated with us that they are agreeable with that statement, with these revisions. And no changes or revisions were made to the rule.
Any questions on that update with a subtle change from last month then? All right. Anyone signed up for public?
This is Christy. I do have a question.
Yes, please.
So, hang on. We're doing this transition. I'm sorry. I'm with you guys now.
Okay.
The In this document, there's discussion about not covering cell phone service for the month, but that it will purchase phones. Is it for safety reasons? So I just need some clarification around that, because I feel like if we need to purchase the phone, don't we need to purchase the service to make it safe?
We did make we included in our household setup expenses, and there's a set amount of money available to each client to purchase items to help them set up a household in the community. And with this provision, we added the purchase of a cell phone for if that cell phone is needed for safety purposes.
And monitoring.
And monitoring. We're not allowed to, through the legislative act, the initial CTS act, we're not allowed to pay for ongoing monthly expenses. So in the same way, through our household setup funds, we can pay the first month's rent, but we can't pay ongoing rent. And so it follows into that same category. A cell phone monthly expense would be ongoing. We don't pay for ongoing of any household expenses on an ongoing basis.
But we pay for safety monitoring, which is a monthly expense on any of the, button. Help I fall and I can't
Yes.
get up.
Personal
program.
emergency responses, yes, we do pay
Yes,
for those.
yes.
That's a benefit. That's a waiver benefit.
So that's ongoing, the same as a cell phone would be if I text, because I don't use it as a phone, I use it as a texting device. It'd be the same thing.
The difference is that the personal response system is a benefit, as a Medicaid benefit, so it's paid as a benefit. We're talking about the household setup fund that is allowed per client, and that's only $1,500. And that household fund is used to can pay security deposit, to pay for pest eradication, household items, furniture. So many of our clients who are coming out of care centers, they don't have anything. So that $1,500 is meant to cover all of those expenses. So first of all, there wouldn't be enough money in that fund to cover a monthly cell phone expense. But the guidelines around that household expense are that we cannot pay for a monthly expense out of that household setup.
Is it, does the monitoring come out of a completely different pot of dollars then? Because this really is the transitional services to get them set up. And then the long-term stuff would come out of a different pot. So that's where the initial payment for a cell phone would be there, but not ongoing monthly.
Yeah, it's exactly.
Okay.
It's meant to set the client up in a community setting, and part of the service provision is to make referrals and to waiver other types of informal and formal supports and services.
So ongoing support could then. Does that make sense, Ms. Blakely?
Yes, I do understand.
Okay.
Thank you.
Any other questions on document 2? All right. Seeing none and nobody has signed up for public testimony, would anyone like to sign up for public testimony on document 2? All right. We have a motion and a second. All those in favor signify by saying aye.
Aye.
Ms. Blakely?
Aye.
Dr. Young?
Aye.
All right. We have final permanent adoption of document 2. Thank you very much.
Thank you very much.
Document 3, if I could have a motion.
Move the final permanent adoption of Document 3, MSB 15-02-16-A, revision to the medical assistant eligibility rules concerning parents and caretaker relatives, Section 8.100.4.G.3. incorporating the statement of basis of purpose and specific statutory authority contained in the records.
Second.
Got a motion and a second on document 3, and we have Ana Bordalo and Maribel Guadarrama. You're going to be here a while, it looks like, on our agenda.
It looks like it. Happy Friday, everyone. Mr. President and board members, thank you for your time today. So my name is Maribel Guadarrama, and I'm the Eligibility Policy Manager for the department. I am here again to present the proposed rule concerning the income standard for the parents and caretakers relatives Medicaid category. This rule is being brought to you as an emergency due to the need to align with federal regulations effective as of April 1st, 2015. The purpose of the rule is to modify the eligibility income standard for the parent and caretaker relative category from the current 100% of the federal poverty level, MAGI equivalent, to the federally approved 60% federal poverty level, MAGI equivalent. When we presented this rule last month, we discussed that the policy update was going to be built into CBMS by the end of March. This did occur as planned, and we are very happy to say that we have not had any negative impacts as a result of this policy and system change. As expected, 98% of those parents that were between the 69 to 107% of the FPL were relabeled, per se, into the MAGI adult category. So this means that there was no changes to them whatsoever. It was just basically behind the scenes change in labeling of which category they're eligible for. The remaining 2% of the population had Medicare and were determined for eligibility within the Medicare Savings Program. Also, as expected, there was just a handful of clients that were no longer eligible for any program. We are finalizing the list of these clients so that we can provide them to our partners at Connect for Health Colorado to do outreach and assist with purchasing a qualified health plan if they so choose to. Other than this, is there any other questions that I may answer?
No changes since last month on this rule when it was presented as an emergency.
Correct. No changes.
Ms. Riley?
Just to clarify, this is on a final permanent adoption, not emergency rule, is that correct?
Correct. It came last month as an emergency. Right.
Thank you for that.
Yep. Okay. Any questions from the board on this one? We don't have anyone signed up for public testimony. Would anyone like to sign up? And seeing none, we've got a motion and a second for final permanent adoption of document 3. All those in favor, signify by saying aye.
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 Ms. Blakely?
Aye.
Dr. Young?
Aye.
Great, thank you. We have final permanent adoption of document 3. Thank you very much. I think you can stay there, it looks like.
Oh, yes.
We'll move into our initial rules agenda. We have 8 rules to be heard on the initial agenda. If I could have a motion for document 4, please.
So I move the initial approval of document 4, MSB 15-02-23-A, revision to the medical assistance eligibility rules concerning Section 214 of the Children's Health Insurance Program Reauthorization Act of 2009, parentheses, CHIPRA, end parentheses, Sections 8.100.1 and 8.100.4.G.2, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Second.
Got a motion and a second on document 4, and we have Maribel back with Anna this time. So welcome.
Good morning, Mr. President and board members. Thank you for your time today. My name is Ana Bordalo. I am the Child Health Plan Policy Specialist, and I am here today to present the rule on the removal of the 5-year waiting period for lawfully residing children eligible for Medicaid. The Children's Health Insurance Program Reauthorization Act of 2009 grants states the option to provide benefits to children and pregnant women who in Medicaid and Child Health Plan Plus who are lawfully residing in the United States and who have not met the 5-year waiting period. Currently in state policy, we do, in state policy, pregnant women lawfully residing are eligible for Medicaid without a 5-year waiting period. The Colorado House Bill 09-1353 was authorized in 2009, and funding for the House bill was provided effective July 1st, 2014. With funding available, the department is now able to implement this policy change for lawfully residing children for Medicaid if all other criteria are met. The department overlooked a section that also needed to be revised as part of this rule change. Children eligible for presumptive eligibility who are lawfully residing in the United States and who have not met the 5-year waiting period are also eligible for Medicaid for 45 days until a true eligibility determination is made. Currently, in state policy, pregnant women lawfully residing are eligible for presumptive eligibility without a 5-year waiting period. Changes to the Colorado Benefits Management System will be made to be in alignment with the federal regulations effective July 1st, 2015. The department has coordinated with our communications department to develop a communications action plan for stakeholders and consumers to help communicate the policy change. The department has also collaborated with Connect for Health Colorado to discuss the department's action plan to be in alignment with the messaging these individuals will receive. And the department is in the process of updating the FAQ sheet for the 5-year, for the removal of the 5-year waiting period as well. And we will also like to thank Colorado Coalition for Medically Undeserved, Colorado Community Health Network, and All Kids Covered for their feedback on the policy change. With that said, are there any questions regarding the policy change?
My understanding is that there is an R page.
That is correct for the presumptive eligibility rule change.
And that's on all of our iPads.
Yes.
So the first thing I think we need to do is have approval or a motion and approval to accept the R pages.
So I would move to accept the R page on our tab. It's R11.
Okay.
Second.
All those in favor of acceptance of the R page?
Aye.
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 Dr. Young?
Aye.
Thank you.
Aye.
All right, we've accepted the R page into the rule. Questions on the rule itself from anybody here? Anyone on the phone have questions on document 4?
Nope, I'm good.
Okay. And we don't have anyone signed up for public testimony. Would anyone like to sign up? Seeing none, we've got a motion and a second for initial approval of document 4. All those in favor signify by saying aye.
Aye.
Ms. Blakely?
Aye.
Dr. Young?
Aye.
Great. We've got initial approval of document 4. Thank you both very much. Then we'll move into document 5 then with a motion.
Move the initial approval of document 05 MSB 15-02-23B, revision to the Child Health Plan Plus rule concerning Section 214 of Children's Health Insurance Program Reauthorization Act of 2009, CHIPRA, in parentheses, Section 10, incorporating the statement of basis and the purpose and the specific statutory authority contained in the records.
Second.
Second.
We've got a motion, a second, and a third on document 5. And again, we have Anna and Maribel.
Hello. So my name is Ana Bordayo. I'm, as mentioned earlier, the Child Health Plan Policy Specialist, and I'm here today to present the rule concerning the removal of the 5-year waiting period for lawfully residing children and pregnant women who are eligible for the Child Health Plan Plus program. The Children's Health Insurance Program Reauthorization Act of 2009 grants the states the option to provide benefits to children and pregnant women in both Medicaid and Child Health Plan Plus who are lawfully residing in the United States and who have not met the 5-year waiting period. As I mentioned earlier, the Colorado House Bill 09-1353 was authorized in 2009, and funding for the House bill was available effective July 1st, 2014. With funding available, the department is now able to implement this policy change for lawfully residing children and pregnant women eligible for the CHIP program. The department overlooked a section that also needed to be revised as part of this rule change. Pregnant women and children eligible for presumptive eligibility who are lawfully residing in the United States and who have not met the 5-year waiting period are eligible for 45 days until a true eligibility determination is made. Changes will be made to the Colorado Benefits Management System to be in alignment with the federal regulations effective July 1st, 2015. And the department has also coordinated with the Communications Department to develop an action plan for stakeholders and consumers to communicate this policy change. And as I mentioned before, the department has also collaborated with Connect for Health to discuss the department's action plan and to be in alignment with the messaging. And we are also going to update the FAQ sheet for the removal of the 5-year waiting period. That's it. Are there any questions regarding the rule change?
No. Again, we have an R page that I'd need a motion on.
I'll move the approval of R2, page R2, the R page for this rule.
Second.
Okay, we've got a motion and a second for approval of the R2. All those in favor, signify by saying aye.
Aye.
Aye. Ms. Blakely?
Aye.
Dr. Young?
Aye.
All right, we've got the approval of the R pages in there then. And then specifically on the rule itself, on document 5, are there any questions from the board? And seeing none, and nobody is signed up for public testimony, if anyone would like to sign up, please let us know. And if not, we do have a motion and a second for initial approval of document 5. All those in favor, signify by saying aye.
Aye.
Ms. Blakely?
Aye.
Dr. Young?
Aye.
Very good. We have initial approval of document 5. Thank you both very much.
Thank you very much. Have a good day.
Document 6, if I could have a motion.
I'd like to move the initial approval of Document 6, MSB 14-10-15-B, revision to the Medical Assistance Health Programs Benefits Management Rule concerning family planning, Section 8.730, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Second.
Got a motion and a second on document 6, and we've got a whole group of people here. We have Valerie Baker-Easley, Melanie Reese, and Frank Herbst here. Welcome.
Thank you. So my name is Valerie Baker-Easley. I'm the manager of the benefits section for Medicaid. And with me is Dr. Melanie Reese, who is our subject matter expert on women's health benefits, and Frank Herbst, who is our senior compliance officer. We will be presenting 3 rules. The first of these will be the family planning rule, and so I'm going to turn that over to Melanie, who will make that presentation.
Good morning, Mr. President, and board members. Again, my name is Melanie Reese. I'm the Family Planning Benefit Manager for the department. First, I want to inform you that we did extend the opportunity to stakeholders to provide feedback, both during the family planning collaborative benefit process as well as with the public rule review. We received no stakeholder feedback during those 2 sessions. However, we did receive some late feedback from the Colorado Center on Law and Policy yesterday, and we were able to successfully address their questions. There are a couple of questions that were for clarification, and one area that they pointed out might be worded and rephrased a little better. So we will look at that and bring that before the second reading to the board. So I'm bringing the family planning rule to you this morning because the department has identified that there are several sections in the old rule that really needed to be more appropriately placed elsewhere in rule. There are really only a few modifications to this rule. A portion of the rule changes as identified in the crosswalk, and I noticed that you did get an abbreviated version in your packet, but I did provide copies of the extended document if you need that.
Thank you.
A portion of the rule changes really identified the result of the department's effort to try to standardize the formatting of rule. So we added some headings and sections about provider eligibility, covered services, non-covered services, etc. We also deleted 2 sections from the original rule. We deleted the section that was related to hysterectomies. We placed it more appropriately in a new women's health services rule. And we also deleted the section on abortion services to make it a standalone rule. We removed the definition from the old rule that defined health in life-endangering circumstances and appropriately put that into the abortion services rule. We did add 1 section to the new rule, and that related to sterilization consenting rights for individuals with developmental disabilities. I abbreviated that as IDD in the crosswalk. And right below that section, we also identified and made clarifying statements that the age requirement for valid informed consent for sterilization procedures were compliant with federal law, which was the 21 years or older. We added a few words in the family planning services provided, and we specifically added the wording, a phrase related to the intent of family planning services. And we added that in order to be more compliant with federal family planning directives and family planning service guidelines. 2 specific places that we added that phrase related to intent was under the family planning service definition, and we added the phrase with the intent to delay, prevent, or plan for a pregnancy, and again to align with federal guidelines. And the second place was under the heading documentation and services, where we added the request that the intent of the family planning services as it related to delaying, preventing, or planning for a pregnancy be documented in the client's medical records. Finally, following the new rule standardization formatting that we modified the original sterilization section. We separated it into 2 different areas, one under sterilization service requirements, and the second we made a section under sterilization consent documentation requirements. There are no contextual changes from the old to the new document. However, we did reword it in order to make it easier to read these federal sterilization regulations and requirements. So I thank you for your time. Are there any questions that I can answer for you?
Just to be clear, to set the stage for the next 2 rules as well. This rule, then you said you took out the abortion component, which is a rule that we'll be looking at after this, and then as well as the women's health rule, which is also we'll be looking at after this.
That is correct.
Okay. Dr. Mlechkovich?
I guess just to be clear, what I hear you saying is that you made a number of technical changes in the rules, but the services that are available to clients are essentially the same.
That is correct.
They're just found in different parts of different rules. Is that right?
We reformatted it. That's correct.
Okay.
Ms. Roberts?
Thank you, Mr. President. I just have a clarifying question. 8.730.4C on contraceptives, I assume FDA approved include the implantable devices in fallopian tubes as well as the arms.
That is correct.
Thank you.
Any other questions from the board on this? We don't have anyone signed up for public testimony. Would anyone like to sign up for public testimony? Seeing none, we have initial, a motion and a second for initial approval on document 6. All those in favor, signify by saying aye.
Aye.
Ms. Blakely?
Aye.
Dr. Young?
Aye.
Okay, great. We've got initial approval of document 6. It sounds like there may be a little bit of wording change coming back.
That's correct.
Between now and next, so we won't put this on the consent agenda then.
Just one little section.
Okay.
Is this an R page or is this clarification?
We don't have an R.
Just a crosswalk.
Yeah, that's just.
That just happened yesterday.
I'm just going to put both of them.
Okay, then we have the next 2 rules that will also be working with this, and so if I could have a motion for document 7, please.
I move the initial approval of document 07, MSB 14-11-19D, revisions to medical assistance health programs office, benefits and operations division rule concerning women's health services, section 8.731, incorporating the statement of basis and purpose and specific statutory authority contained in the record.
Second.
Got a motion and a second on document 7. Thank you. And again, we have Valerie Baker Easley and Melanie Reese and Frank Herbst here.
Thank you, Mr. President. So this is a new rule, as we mentioned with the family planning rule. The department created a benefit coverage standard around women's health services to identify and to define these services in one place. So what this rule sets forth is the frequency, scope, and duration of those services in this new rule for consistency with the department's other benefits. So as you've seen other rules, this is the way we set forth the benefits that are covered, and this provides that same context for the women's health services. And now they are their own standalone rule as opposed to being part of family planning. As far as so you do have the crosswalk, which is slightly updated from the original version that I think you received on the iPad. Primarily what we've done here is to move the content. It was originally included in 8.730.3, which is family planning services, but is now being defined separately because these services actually comprise women's routine health care. The specific nature of family planning, as well as the fact that it's governed differently at the federal level, supports our decision to pull out and identify separately these routine women's health services. From the crosswalk, you see that the main change is in the numbering. This rule sets forth the usual information on client and provider eligibility that you've been seeing in the new rule template that we've been bringing to you. It includes covered services, non-covered services, and prior authorization. BRCA screening for breast cancer is also now included in the rule. We did have stakeholder involvement as we put this rule together. We received and incorporated inputs from several stakeholders, and the key ones included the Susan G. Komen Colorado Foundation for breast cancer, the Colorado Department of Health and Environment, Colorado Community Health Network, and genetic counselors representing Centura Health. And for most of those stakeholders, we did implement a number of the suggestions that they made as far as clarifying and defining services. For a few of them, they had asked us to put in considerably more detail than is really appropriate in a rule. And for others, they wanted a lot of detail on genetic testing, which we do have in the genetic testing benefit that we're developing that will be coming to you in the months to come. So that's sort of a summary of the stakeholder feedback that was involved and how we worked with it. I do want to call out a technical correction in this rule, and we do have the R page. I think you've got a copy of that. We have, in the section covered services, where medical necessity citation is provided, we're missing a number in that citation. We're missing a 1. And so Judy Carey's made the change, has created the R page, and we request your approval with that citation as a part of the rule.
So can I have a motion to approve the R page?
So I move approval of the R1 page.
Thank you.
Second.
Got a motion and a second to approve R1. All those in favor, signify by saying aye.
Aye.
Ms. Blakely, thank you. Dr. Young?
Aye.
All right, we've got approval of the R page.
And that concludes the remarks that I have on this rule, so I'd open it to any questions that you all may have.
Dr. Malinkovich?
Thank you. This is just a point of clarification. Women are eligible for a number of other health benefits besides these, as are men and children. How have you? I'm trying to figure out why we isolate out a set of women's health care benefits and don't just include it in all the rest of the health benefits that are available. Can you give me some history on that or clarification?
Yeah. So because this was originally part of family planning and did correspond primarily to women's services, what we wanted to do was to pull out the pieces that didn't belong in family planning, as we've already mentioned, and create a women's health benefit that covered the routine services that are specific to women. So there are other services that would correspond to men. You know, one of the examples that we talked about in preparing for this meeting this morning was men can get breast cancer. Men can need testing for that. And we do have other rules, genetic testing, physician services that cover those kinds of things, but this particular rule is designed to be specific to women's routine health care. Does that answer your question?
Do we have one specific to men's health care?
We don't at this
Right.
time.
Just-
Is that a suggestion?
No, I'm just wondering about the history of I'm supportive of all the services. I'm just interested in how we isolate out the benefits and how we define the benefits in the rules.
Yeah, and for the most part, this focuses on women's reproductive health, so that tends to be a category of its own that is unique from men and children.
Ms. Roberts?
Thank you, Mr. President. Dr. Reese, I just am curious, the HPV vaccinations limited to age 26, is that evidence-based that?
That vaccination is also provided earlier through CDPHE immunization process. So,
Yeah, it says 9 to 26, but I mean thereafter. Is there a reason not to provide it thereafter?
I can't answer that exactly, but I'm happy to bring that.
I'm just curious.
I would imagine, I don't know. Let me find that out and bring that information back.
I would assume people are still sexually active.
It may be related to exposure rates or anything, but I honestly can't tell you that, but I would get that information.
Thank you.
Any other questions? I just want to make a comment of really appreciating the crosswalks that you put together. It really makes following the rule and the changes much more simple for all of us. Yeah, I do appreciate that.
Maybe.
We don't have anyone signed up for public testimony on document 7. Is there anyone here that would like to sign up? And seeing none, we've got a motion and a second for initial approval of document 7. All those in favor, signify by saying aye.
Aye.
Ms. Blakely?
Aye.
Dr. Young?
Aye.
All right, thank you. We have initial approval of document 7, which would move us on to document 8. If I could have a motion.
Move the initial approval of document 8, MSB 14-09-16-B, revision to the Medical Assistance Health Programs Benefits and Operations Division Rule concerning Family Planning Services, Sections 8.730.4 and 8.770 Abortion Services, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Got a motion and a second on document 8. And once again, we have Valerie Baker-Easley, Melanie Reese, and Frank Herbst here. Welcome.
Thank you. So we have abortion here. As you know, this is a new rule that we've created by pulling it out of family planning. It's now its own separate rule. As you can see from the crosswalk, it's been changed in terms of numbering because of the relocation. Because abortion is governed so closely at the federal level, we felt that, as well as the fact that it doesn't belong in family planning, we felt that making its own rule out of it and being very specific in aligning our language with the federal language was important. And so that's what this rule really does. The state only covers abortion in the instances that it's federally covered and approved, so I think it's very important to be consistent with the federal language. Looking at the crosswalk, you'll see that the main changes are formatting for the new rule template, which again would include the client and provider eligibility sections and covered services. That presentation of the information is consistent with what we're doing with the new rule template that you continue to see. Just as a point of clarification, the state covers abortion only in instances of incest or rape or when the woman's life is endangered by the pregnancy. And we do require verification of those circumstances. We require it at the state level. It's also required at the federal level. And the language that we have in this rule around that reflects exactly what the federal requirements are. So any questions about the rule, the benefit?
Any questions from the board? Dr. Malinkovich?
I have one question. I guess I didn't realize this, but if the fetus is non-viable or determined to be non-viable by antenatal testing, that's not an indication, that's not a covered...
Not at this time.
Okay.
Any other questions? See if anyone signed up for public testimony. We don't have anyone signed up for public testimony. Would anyone like to sign up for public testimony on document, what are we on? Document 8?
8.
Document 8. Seeing none, all those in favor of initial adoption of document 8, please signify by saying aye.
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 Ms. Blakely?
Aye.
Dr. Young?
Aye.
Very good. Thank you all very much for simplifying those 3 rules for us. Appreciate it. All right, let's move on to document 9. If I could have a motion.
Move the initial approval of document 9, MSB 15-01-26-A, revision to the Medical Assistance Home and Community-Based Services for Elderly, Blind, and Disabled rule concerning respite care. Section 8.492, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Have a second?
Second.
Got a motion and a second on document 9, and we have Cassandra Keller and Candace Bailey here.
Good morning.
Good morning.
Thank you, Mr. President and members of the board. My name is Cassandra Keller, and I'm a waiver administrator in the Long-Term Services and Supports Division. I'm here today to bring forward just a couple of minor changes to the respite service rule, which affects the elderly, blind, and disabled waiver, the community mental health supports waiver, and the spinal cord injury waiver. These slight modifications to the rule are policy clarifications that are intended to reduce confusion among clients and case managers. By changing the service authorization from a calendar year to a certification period, we'll be aligning the respite service with all other waiver services that use the certification period, which will hopefully reduce any confusion among clients and case managers. Furthermore, we would like to clarify the limits on service and any confusion regarding an interpretation of the in-home respite rate being tied to the daily alternative care facility respite rate. We're adding specific language to make it clear that the daily institutional rate being used in the nursing is the nursing facility respite rate, as that's the department's intent for an institutional setting. So we want to make it clear that that's what the rate is tied to. So these are just some slight policy clarifications, just trying to clean up the rule a little bit, making less confusion among clients and case managers. So those are just the basic changes that we're making here today.
Okay. Ms. Riley?
I just want to disclose to the board that I operated a county department that includes the single entry plan that would be affected by this.
Operated, huh? Past tense now?
Well, I'm still alive.
Thank you. Other questions from the board on these relatively minor changes into the rule? No? Nobody has signed up for public testimony. Would anyone like to sign up for document 9? Seeing none, looking for, we got a motion and a second for initial approval of document 9. All those in favor, signify by saying aye.
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 Ms. Blakely, thank you. Dr. Young?
Aye.
All right. What's that? I think that was an aye.
I think it was an aye. I think it was an aye.
So we do have initial approval of document 9. Thank you very much. And move on to document 10. I could have a motion.
I'll move the initial approval of document 10, MSB 15-02-18-B, revision to the Medical Assistance Health Information Office rule concerning provider screening regulations, section 8.125, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Second.
Got a motion and a second for document 10. And here to present is Nathan Colkin and Kyle Brown.
Good morning, Mr. President and board members. My name is Nathan Colkin. I'm the Deputy Division Director for the Health Information Provider Payment Division. I am here to propose this rule because the department intends to implement the Affordable Care Act's provider screening requirements as issued by CMS. I also have here Kyle Brown here today with me because prior to him leaving to the governor's office, he was the lead for implementing this rule for the department. So he has more of the technical knowledge than I do. But this rule applies to all Medicaid and CHIP Plus providers, and it is designed to prevent fraud, waste, and abuse. Providers are required to revalidate enrollment at least every 5 years, and all providers that are currently enrolled with the Medicaid program will have to be revalidated by the end of March of 2016. So this also includes the ordering, referring, and prescribing providers that they also enroll through the department as well. An application fee is also will be required for some of the providers also. All providers, they will be thrown into 3 risk categories, and that's an area that the department, we are still working on within this particular rule. And we have received some comments on this rule from the AG's office, program integrity, and our program staff. So next month we do plan on having this updated as we go through all of their updates.
So if I understand you right, next month when this comes back for second reading, you'll have a better definition on those pools, those risk pools?
So yeah, just to follow up on what Nathan was saying, a lot of the risk assignment levels are set by the federal government, so we don't have any flexibility there. And then the rule, actually, the way it's drafted now, sets out those risk assignment levels. So the edits from the Attorney General's office will be minor, and they won't be substantive in nature.
Okay. Thank you.
So I think it's just to follow up on what Nathan was saying. Obviously, this is something, we talked about this about 2 months ago, just kind of as an update. So I don't want to go through the entire presentation again and bore you all. But just as a reminder, as Nathan said, this is something that is required of the state by the Affordable Care Act, and it's about preventing waste, fraud, and abuse. Providers are required for the first time to periodically revalidate their enrollment. There is a requirement in the Affordable Care Act that each provider who's enrolling who doesn't meet certain exemptions pay an application fee. And I did want to address that specifically because there was some discussion at the last meeting about concerns about the payment of the application fee and what it would do to our provider networks. And it is the department's intention to seek a global fee waiver for every provider in Colorado. There will be other options that, depending on the conversation with CMS, we will still make it, the department still intends to make it its priority to exempt as many providers as possible. Obviously, primary care and dentists are at the top of our mind, but every provider in Medicaid there's a potential challenge there. So just to keep you posted on that, the rule has permissive language that would allow the department to exempt providers from the fee, given the concurrence of the federal government. Unfortunately, under the law and under federal regs, we don't have unilateral authority to waive the fees whenever we want to, so that will require a conversation with our federal partners. But the rule, as currently drafted, will allow the department to exercise that authority. We mentioned some of the screening requirements that Nathan mentioned, the risk levels. Most of our providers will see very little change in the way that they are screened when they enroll. They'll just need to make sure that they're meeting state rules and regulations, and that they have an up-to-date license, and that they're not excluded from participation in Medicaid or Medicare. Some of our providers will have to undergo an on-site inspection, and others will have to undergo a very small proportion will have to undergo criminal background checks and fingerprinting. So with that, I think since you're so familiar with the whole, with this rule, I think I just ask if you guys have any questions.
Ms. Gibbons?
I just have a process question in relation to, so they re-enroll every 5 years. Mm-hmm. Is there some notification of that so that, or is that something the providers need to stay on top of?
My understanding is Nathan is our lead on the new provider enrollment tool, but my understanding is that there is some sort of electronic notification that goes out to providers when they need to re-enroll.
Thank you.
Ms. Roberts?
Thank you, Mr. President. I need to reveal, too, that I am a director of a hospice. And thank you, Kyle, for clarifying, rather than needs assessment, perhaps, that the global waiver would be, I'm sure everyone would appreciate that. Thank you.
Ms. Riley?
A couple of things. One is that everybody who's on now has to re-up by March of 2016.
That's right.
And so that's a lot.
Yes, it is. Yes, it is.
And
It's a huge lift for providers. It's a huge lift for the department. Them's the rules, right? Yep.
And so I guess I'm wondering, is that something that the department is prepared, particularly with all of the ones that would need site visits? I see on page 5 of 10, near the bottom on revalidation, the wording for whether someone would lose their Medicaid status as a provider is a may on the part of the department, and all the other places I saw on the bill is a shall. And it says that the department may terminate the enrollment of the provider if they don't do their revalidation.
Right.
And
yeah, so I think it's a matter of.
is that to protect you in case you can't get to all of it? Okay. Good plan.
No, I mean, obviously, I don't think it's the intent of the department to penalize providers for a capacity issue. And I know that now I've been away from the department for about 3 months now, but when I was here, it was very much we were in ongoing conversations with our vendors as well as our other state partners to make sure that we would have the capacity to meet those on-site inspection requirements.
The other question I have is just because this is very complex, and I'm a little concerned about some of the family providers, like NHCBS, it's a family member who is actually being paid by Medicaid to provide the service. Are they also going to be required to register and pass the background checks?
So it depends on the program. So all of our providers need to be enrolled in some way. But in the case of, I think if you're talking about the client-directed services programs, and I'm getting the name wrong there, but I think you know what I'm talking about. Those particular CDAS, that's what I'm talking about. They are actually employees of a larger of the sort of financial management service and so the financial management service that the department contracts with is the enrolling entity in that particular case. And since those folks are not what's considered the family member in this particular case who's providing the service is not what's considered an ordering, referring, or prescribing entity, they do not necessarily have to go through
so that
the
parent
enrollment.
organization would have to do
Yes,
the
and they also don't have to go through the screening in the same way. So.
Great. Quick, just follow up on that, I guess. I know you're at the governor's office now. Is the department's intent really not to penalize any providers if it's a capacity issue?
Yes,
and I make sure to hear from the department on that.
Sure, I can take that. So this is Gretchen Hammer. This topic was a topic of conversation at our senior executive team meeting just last week. So we are very aware of the work. We are getting through this regulatory process and also convening internal meetings that are cross-departmental to understand what will be our approach, how will the communications be in line, how will we get the capacity in line. So it is very much a time frame that we're looking toward, and we anticipate being ready.
Great. Thank you.
And I just on the fee waiver issue, Chris Underwood, who couldn't be here today, who used to be my boss and is Nathan's boss, is the entity, or he told me basically to say that. So anyway, so the department's in lockstep on that.
Thank you, Ms. Roberts.
Thank you, Mr. President. I'm curious about, following up on Jenny's question, how amiable is CMS to be out there doing these site visits for those that have not had one, that are regulated every 3 years, every 5 years, or what have you. Did you get any pushback?
So the department is required to do the site visits under the Medicaid program. CMS, as for Medicare providers, does some site visits as well. And we can rely upon those site visits and enrollments to some degree provided that they took place within the last year.
Which, for hospice providers, for example, they have stated now that it'll be every 3 years. Our
Right.
first one was something like 11 before we were reevaluated.
And so that's where the fee waiver comes into place, right? That there are contingencies that we were talking about where, you might be able to convince the federal government to extend that year-long sort of reliance period where we can rely upon the Medicare.
So the windows match.
So it's the windows match, or so that, and I know that the community health centers, the FQHCs, are very concerned about this issue. The department has been in constant communication with them about this because they don't want to have to pay the fee more than once, and so hopefully the first is exempt everybody, and then we can talk about what the other options are after that.
Thank you.
Any other questions from the board? Doesn't look like we have anyone signed up for testimony on this. Would anyone like to sign up for document 10? Seeing none, we have a motion and a second for initial approval of document 10. All those in favor, signify by saying aye.
Aye.
Ms. Blakely?
Aye.
Thank you. Dr. Young?
Aye.
Great. We've got initial approval of document 10. Thank you. It does sound like there will be some minor changes maybe from the AG's office coming back.
Right, so you don't need to put it on the consent agenda.
Thank you. Moving on to our last rule.
Thank you.
Yes.
I'll be back next month.
All right.
Sorry, we have another. Right. Yes, thank you. We're the next item on the agenda, aren't we?
So our last rule is document 11. If I could have a motion on that.
Move the initial approval of document 11, MSB 15-02-18-C, revision to the Medical Assistance Health Information Office rule concerning enrollment procedures, section 8.013.1, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Second.
Got a motion and a second on document 11. Thank you. And again, we have Nathan Colkin and Kyle Brown.
All right. Thank you. This rule is to update the provider enrollment specifically around the out-of-state providers. Currently, as of today, there's a limitation. We don't take in as much of the information for out-of-state providers as we do the in-state providers. But due to the fact that the Affordable Care Act's provider screening requirements, we are now required to treat out-of-state providers the same way as we do in-state providers. And that's what this rule is for, is just to update the enrollments for out-of-state providers.
Pretty straightforward. Any questions from the board? Ms. Riley?
So if an out-of-state provider goes through all of this in the state where they are, can we accept that state's?
Yes, you can accept that state's enrollment. It follows the same rules as if the CMS, if they went through their provider screening enrollments in the last 12 months in that other state, we can accept that.
Great. Ms. Roberts?
Thank you, Mr. President. Also, assuming these out-of-state providers are practicing within the state as well, perhaps cross-county lines or state lines, I should say, they have to be licensed in the state of Colorado as well. Is there the caveat to that? I missed it.
All licensure requirements would still hold. So yes.
So first and foremost, they have to be licensed in. Okay.
So if we require them to be licensed in Colorado, then we require out-of-state providers to be licensed in Colorado.
Thank you. Okay.
Great. Any other questions from the board? Nobody has signed up for public testimony on document 11. Is there anyone who would like to? Seeing none, we have a motion and a second for initial approval of document 11. All those in favor, signify by saying aye.
Aye.
Ms. Blakely?
Aye.
Dr. Young?
Aye.
Great. Thank you. We have initial approval of document 11. Appreciate it.
Thank you.
As I'm looking at the consent agenda motion then, I have down documents 4, 5, 7, 8, 9, and 11. Good with where folks are? So if I could have a motion for the consent agenda.
So
Move to add documents 4, 5, 7, 9, and 11 to the consent agenda.
And 8.
And 8.
And 8, I missed 8, excuse me.
Great. I've got a motion. I have a second.
I'll second.
Thank you.
Tried to get away.
All those in favor, signify by saying aye.
Aye.
Aye. Ms. Blakely?
Aye.
Dr. Young?
Aye.
Great.
So I'll move that all rules adopted at this meeting of the Medical Services Board of the Colorado Department of Healthcare Policy and Financing meet the criteria of the State Administrative Procedure Act, which are incorporated by reference.
Second?
A motion and a second on the closing motion. All those in favor?
Aye.
Ms. Blakely? Dr. Young?
Aye.
Great, thank you.
Can I ask one question?
Yeah, we just closed, but yes.
Sorry,
That's
I
okay.
didn't get in. I just was curious where we are with the other appointments.
Oh, we'll follow up on that on department updates here as we
Okay,
move.
thank you.
As we move forward. Thank you. Did we vote on the closing motion? Yes.
Yes.
I think we did. All right, we're closed. We do have one individual signed up for open forum. Julie Farrar, would like to come up? Introduce yourself and who you represent and what's on your mind.
Thank you. My name is Julie Farrar, and I am the policy analyst for the Colorado Developmental Disabilities Council. And I just wanted to give an update on the guardianship rules that were brought before you last month to let you just give you an update.
Great, thank you.
And so I just wanted to let you know that we have been waiting for some language out of the Attorney General's office that may help us with moving forward. And there have been conversations around that. And I'm very positive that Jerry Froney, as an involved family member, will make sure that we are up to task, and we are looking at having scheduling that meeting of all of the stakeholders. We were waiting for the information from the Attorney General's office first, so just wanted to update you.
Wonderful. Questions from Ms. Farrar? Great. Thank you very much for the update. Appreciate that. Would anyone else like to sign up for open forum? Seeing none, then we'll move forward with, where are we on the agenda? Thank you. Department updates. Part of our packet, we had the House Bill 1293 hospital provider fee update is written, and so please make sure to take time to look through the provider fee. And then the next, I'd welcome Eric Stricka forward to kind of give us an update on the legal immigration deeming update. Welcome.
Thank you. Good morning, Mr. President, members of the board. Kind of host them with here. So I'm just here to give an update on where the department is. My name is Eric Stricka. I'm the long-term sports and services eligibility policy analyst for the department for the state. And I'm here to give an update on the methodology on a requirement we have to deem income and resources to non-immigrant applicants from their sponsors. So it's been, we've requested a policy opinion paper from the Colorado Centers for Law and Policy, and we incorporated their findings into our proposal. And our goal really is to be in alignment with the federal regulations, but also be as least cumbersome to our clients. So what we've come up with, we've proposed the methodology and submitted that to CMS. So we still have not heard back from them, so we're waiting on that. Once we do that, we'll go forward with any kind of policy rule changes, any kind of state plan amendments, those kind of things that we'll need to do. The proposed policy hopefully will be less restrictive than the cash assistance. We want to try and keep individuals, or even possibly maybe recapture some that have lost those benefits through losing their cash assistance. So we'll hopefully go forward and find that. I just want to assure that all the other things that are required under that to exempt certain non-citizen applicants from this deeming policy, we'll have that in our rules and everything going forward. So that's just an update where we're at. We haven't heard back from CMS yet, but they have our proposal, and hopefully we'll hear back soon.
Quick question. I forget the gentleman's name from VOA that brought this to our attention a long time ago, several months ago at least. Are you keeping him in the loop? And
Lucas Atkins, I will.
Let's make sure we just kind of keep him in the loop too, because I know he came with a great deal of concern over this.
A couple of times.
Yep. Great. Thank you. Any other questions? All right. Appreciate the update.
Thank you.
Now we have an update on the Peak Health mobile app. Antoinette Toronto, welcome. Oh, these presentations. This presentation is on our iPad. You'll be able to follow along.
Good morning, Mr. Chair and members of the board. I'm Antoinette Taranto. I'm the Chief Client Officer for the department. And I'm going to try to look back and forth. There's television. So hopefully this is the highlight of your meeting today, because I'm going to talk about one brand new way to engage with our clients and our consumers, and that's our mobile app. So if we go to slide 3. What is the Peak Health mobile app? And I'm going to talk a little bit off slides because you'll have the content that's on the slide. Really what we wanted to do is figure out a way to give consumers another way to get what they need from us. So we all know that, we have our call centers, we have our county offices, we have all of our community partners and contractors that provide healthcare services, and we all get bombarded with some real basic things. So we looked at our call center, and we picked off the top 5 reasons people call in. I need a medical card. What are my benefits? How do I find a doctor? And I forget what they all are. I need to update my information. And and the pay stub, exactly. So let's see, did I get them all? What is my Medicaid status? See, it's been a while, so I forget what those top 5 are. So what we wanted to do is put that in a mobile app. The reason we decided to put it in a mobile app is because when we brought up healthcare reform and we were required to have an online application that did real-time processing, what we found is that about 60% of all applications coming in came in through Peak. So that pretty much told us that we have a strong client base that is comfortable with the internet. Out of that population, about 1/3 of them were hitting our website from a mobile device. So again, we were taking statistics that we already had. Most of them are Android, which makes a lot of sense because Android is the phone that you're going to get pay as you go. It's less expensive than Apple, so on and so forth. So what we wanted to do is create a mobile app. We did one for Apple and for Google for Android. So we have that, and then we also have a what's it called? It's like a web-enabled for your phone. So sometimes when you go to a website and it formats it all for mobile, it does that as well. So that we pretty much cover anyone that's using a mobile device, we have them covered. Let me see if I missed anything on this slide. The other thing I wanted to do with it is we all know that, if you use a mobile phone, you install and uninstall apps rather quickly if something isn't quite right or you're not interested in it. So what we want to do is sort of give you the basics of what you need so that our call centers and our resources can spend more time on doing things that are more complex. So we're creating self-service, giving people a little bit more independence. They don't have to call us for it, but then also front and center on the mobile app, and you can look in the stores for Peak Health. Front and center are health tips on nutrition, happiness, health, fitness, and what we want to do is you're going to go there to do the basics day to day. I'm on the go and I need to get these things done. But while I'm there, hey, here's something about riding my bike, with my kids. Or, let's start, onboarding and embedding some of those healthy tips from a reliable source. And at some point, we hope to expand that to offer programs and so on, and track your preferences and make it really personalized. So on slide 4, this shows you what I already mentioned, the statistics. About a third are already accessing our site. So I really already talked about that. The other thing we did put on the mobile app is the customer service phone number, as well as the quit line and the nurse advice line. So from the app, they can say, they can click on it and automatically dials in. That also applies to our provider directory that we have, and that's all Google Maps as well. So if you have a doctor that's your favorite, you can mark it as your favorite, and then you can go in and right there find it and push the phone number and it dials right in. So we're trying to make it easier for them to get what they need. So on slide 5, we're actually going to do a demo, and I think you have to click the image. And this sort of walks through everything I just gave you, but it's really pretty. There is volume, and there's also a picture.
I'm not sure how long it will be. With the exception of
These are 50s. To give Colorado Medicaid members a quick and easy way to maintain eligibility, access information, and find nearby healthcare providers that are in their Medicaid network. Our health tips section is front and center with useful information about staying on a path to better wellness. Short articles on fitness, health, happiness, nutrition, and parenting encourage everyone in the Colorado Medicaid community to pursue a healthy and active life. To find a Medicaid provider, just open the map and choose the type of provider needed. Add providers to a favorites list to quickly find them again later. You'll notice right away that this is not a typical health insurance app. Peak Health is an app for Colorado and the people who live here. Designed for both English and Spanish speakers, the app is inviting, colorful, friendly, and well-organized. Maintaining eligibility is a very straightforward process. All information that a Colorado Medicaid member should keep current can be found in the account section. It only takes a few seconds to update a phone number, a mailing address, or household income. Digital medical ID cards and a clear explanation of the benefits provided by Medicaid make it easy to visit a healthcare provider. Now, Colorado's Medicaid community can maintain their status, find information, and coordinate provider care on the go, all through a simple and intuitive interface. This means more knowledgeable and empowered members and fewer customer support center calls. We are the first state to offer this level of accessibility and ease of use to Medicaid members, and we're excited to share it with you. Thank you. Gracias, and have a healthy day.
Is it also in español?
Yes. Yes, it is. And it is also ADA compliant. And we really don't view this as ever done because people's needs change, the world changes around us, and we want to evolve with it. A couple things that I do want to mention now that you've seen it. We've done a couple things that I think are pretty cool. We have the ability now to take a picture of your pay stub and upload it right into our system. So you don't have to go to an office or mail something in for your pay stub. So you get your notice that, hey, looks like you're over income, we need this. Now if you are self-employed, you're going to have to provide, your statements. But for those W-2 workers, they'll just need to take a picture of that pay stub, upload it right in, and off they go. The other thing that I really wanted to make sure that we did for CHIP enrollment fees and for the buy-in premiums. I don't know if you've ever used an app that you can take a picture of your credit card or your check to be able to get that account information off of to make a payment, but there are ones out there, and that's what we're doing as well. So you don't have to type in your 16-digit credit card number or your checking routing and account number. You can take a picture of it. We'll read it. We'll say, is this right? Yes. And then we move on. And you can set it up for automatic payments, manual payments. You're in control. But again, it's easy. That's the whole intent.
Ms. Roberts.
Thank you, Mr. President. Question about all of the initial or the recent break-ins. How well is it encrypted so that the providers are not distributing their data to the world?
That's a great question. So this is linked directly to PEAK, our online application, and all of the security is managed. This is all through OIT. Providers will not have access to the PEAK account or the PEAK mobile app information. That information that's updated goes right into our CBMS system. So this is another face to PEAK.
Okay. Anthem Blue Cross Blue Shield was recently hacked, so that was what my concern was. Is that
yes,
as you know, healthcare is being very targeted by hackers.
Absolutely,
because it has everything.
Absolutely, yes.
Thanks.
So on slide 6, we are talking about. I do need to make it clear. This is for current enrollees. If you have submitted an application, you're pending, we aren't there yet. So you have to have Medicaid or CHIP in order to use it. And we have information on our website for consumers. And then on slide 7, we have a resource center also on our website to help all of our community partners, to spread the word and hear the ins and outs of it, because we really do want to increase use of it. We just started marketing or advertising that this is available. We've had it since December. We've had about 2,000 unique downloads, even just through word of mouth. And also, so when we were doing this, we did a couple of call center surveys. We had about 80 individuals, actual members that were interested in participating, and we did some pretty good user testing, and we modified everything based on the feedback we got from them. So really, again, this is very consumer-centric, and we really want to spread the word now that we're saying, okay, we are going to start telling people about it. Get out your megaphone and let everybody know, hey, this is here, and hopefully this will make your life easier. So if you have any questions for me.
No, it's
looks
good.
great.
Yes.
I just have a comment. I think this is totally awesome. I'm not a tech-savvy person, so I just took the time to kind of get on that mobile app now.
Great.
First of all, I couldn't find it because I didn't enter Colorado Peak Health. So as part of maybe some of the training for some of us that aren't tech-savvy, you just can't go to Peak Health. You have to be Colorado. And then I found out.
Okay.
So pretty
Thank you.
exciting. Thank you.
We'll have to make sure that we put that in our resource center.
Yeah.
It would be great to kind of continue to get some updates on the statistics, every 6 months or so on how that's being utilized. Very exciting, though.
Great.
Congratulations.
Thank you.
Well done.
Yes.
Very good. Gretchen,
Sure.
department updates.
Sure. So I just wanted to maybe note that Melanie went ahead and got the answer to Dr. Roberts' question around, or Donna Roberts' question around the HPV limit. So that was passed out just so that folks have that in their packet. And so that is just, are there any additional questions related to that? Okay, terrific. So
Do we need any other questions? Otherwise, we can excuse Melanie back there.
I would just like to say thank you for your speedy work.
Thank you.
Terrific. Well, thank you. It's great to be here. This is the shortest MSB I've been to since I've joined, so I'm a little exactly. So I did want to start with a little bit of congratulations to Hilltop Community Resources. As many of you know, Mike Stahl is the CEO of Hilltop Community Resources in Grand Junction, and Hilltop just received the Psychologically Healthy Workplace Award from the American Psychological Association in recognition of its efforts to create a healthy, high-performing work environment. So congratulations to you.
Thank you.
There are very impressive statistics that, according to a recent employee satisfaction survey, 100% of respondents believe that the work of Hilltop is important and makes a difference. 90% of employees consider Hilltop's reward and recognition programs meaningful, and 97% report that they feel proud to work at Hilltop, suggesting high morale and a gratifying sense of ownership. So that is fantastic, and congratulations. And we appreciate you taking the time away from Hilltop to be here at MSB, and perhaps we can all learn from some of the tactics you've deployed at Hilltop.
Another really exciting thing I'd just like to kind of throw on top of that, and pat ourselves on the back a little bit. We just received yesterday the Governor's Award for Worksite Wellness in the state of Colorado, as well as the inaugural award for Workplace Wellness.
So are your tactics going to be posted on the website?
We will start presenting those, yes.
Terrific. I think we'd all appreciate learning from them, even here at the department. So congratulations. That's really terrific. Christy.
That is awesome.
Thank you.
Terrific. So I did have a couple of other things beyond that. As you may know, there's a lot of action at the federal level right now related to health care, and some of which directly impacts programs here at the department. So the House has cleared the Medicare Access and CHIP Reauthorization Act of 2015, H.R. 2, on an overwhelmingly bipartisan vote. It was an important piece of health care legislation that made its way through the House, which is an exciting thing to see happen. The Senate failed to take up the measure, however, before departing for D.C. for the recess, which means that there are a few issues remaining before they return to Congress the week of April 13th. But importantly, it's and what I wanted to make sure that you all were aware of is H.R. 2 includes a permanent overhaul of the Medicare Physician Payment Formula, the SGR, that we've heard a lot about, and a 2-year funding extension for the Children's Health Insurance Program. So as you may recall, the Affordable Care Act did some interesting things with CHIP. It reauthorized the program through 2019, but only reauthorized funding through September 30th, 2015. And in part because we're all trying to see what happens when the health insurance marketplaces are in place. Is a standalone or an independent CHIP program still the right approach to providing care for providing coverage for pregnant women and children who are covered by CHIP? Our latest numbers have about 55,000 individuals of both children and pregnant women covered by the Child Health Plan. So it's an important conversation for us to have. What we needed was some federal assurance or federal clarity about what time frame we're working under. If it was at the end of September of this year, that was a very quick time frame. Given this change, it looks like that time frame will be at least a 2-year period. The department is already beginning to engage with stakeholders through some discussions about what do we know about how well CHIP is functioning here in Colorado, what's working that we want to work to preserve, what changes could we make if given the opportunity and the realities that we face. So we have some internal research going on and anticipate, after getting this clarity from the federal level, that over the summer we'll begin with robust stakeholder engagement. It will, require us to all sort of come together and figure out what's best for the kids and families that were currently being served by that program and how that looks given the changing landscape of our health insurance coverage. The other thing that was also in that piece of legislation addresses the qualifying individuals and transitional medical assistance or other so-called extender programs that have typically traveled with Medicare payment patches in recent years, many of which expired on March 31st of 2015. So some federal authorization for transitional Medicaid ended on March 31st of 2015. We got a letter saying from Vicki Joaquino, the acting director, saying that that program is no longer federally authorized. And so we're working to make the changes that are necessary to that, but there are some nuances to that around how we address this lapse in qualifying individuals in transitional medical assistance. So we're not there yet. We're waiting for this piece of legislation, but we anticipate that as that's happened. Dr. Gibbons.
Gretchen, I just had a quick question related to CHIP.
Yes, sure.
When that evaluation is done, will that information come back to MSB?
It certainly can, absolutely.
I think that would be very interesting, since we have seen a lot of information about CHIP on this board. It'd be good to see what the outcomes are.
Sure, absolutely.
We rarely get to see that.
Right. Yes, I had that on my list of something you mentioned earlier. Is coming back.
Of these rules is really helpful. I mean, we see it, but it's sometimes long.
Yep.
Yeah.
Yeah, and I'd imagine, depending on how the scenarios play themselves out, there may be action for the board to take.
That
And
would
so,
be
similar to the provider enrollment, a PowerPoint presentation prior to rulemaking, a couple months in advance, we can certainly plan for that. Sure, absolutely. So the next thing is also there was some federal action related to the Supreme Court on a number of cases, but one we wanted to call into attention was in relation to the ability for private healthcare providers to sue states to raise their Medicaid reimbursement rates. And so the Supreme Court ruled 5-4 that private healthcare providers cannot sue to force states to raise their Medicaid reimbursement rates to keep up with rising medical costs. So we're continuing to evaluate what that means. As has been mentioned, we're engaging in a formal rate review process that is going to look beyond just payment, but also access to care. That's one of the components and why we need a process, and perhaps these 24 individuals who will be sitting on the committee can help to illuminate the realities of access to care. So we're working on some of those components, but we did want to make you aware of that ruling. And again, we've got our attorneys who are looking at this, and we're looking to comply. But we believe some of the rate review process that we've been contemplating already helps us to sort of be in that space appropriately. And then the last thing is just an update on a very exciting grant program that's being worked on cross-organizationally or cross-agency in good partnership with the Department of Human Services. And that's the demonstration grant for testing experience and functional assessment tools, so the TEFT grant. It's designed to test quality measurement tools and demonstrate e-health and Medicaid long-term services and supports. The CMS approved the department's work plan, and we anticipate approximately $3 million in implementation funds over the next 3 years. We're piloting or developing with 7 other states different tools for use with long-term services and supports. As you all have seen multiple times, the development and deployment of those tools is really critical because it can be important for what kinds of services are available. The department is now implementing all 4 components of TEFT. Second round testing for the consumer experience survey among participants in the HCBS EBD waiver and SLS waivers. This summer, the department will also begin pilot and testing for reliability on the functional assessments. And there are a variety of tools that are being developed. I won't go into all the detail unless you all have specific questions, but it's Jed updated both Sue and I yesterday on how exciting this is to have it be such a cross-agency collaboration with CDHS and others. So it's exciting. And then the last piece about the TEFT grant is a key component of that is to create national standards for electronic LTSS data. I think as Antoinette's presentation and all of our other work is to the extent that we can leverage technology appropriately in our public programming, we believe it's the right thing to do. So this will allow EHRs and HIEs to share data across multiple platforms, which continues to be a work in progress on the general physical health side of the world, as we all are aware, and doing that around some of the long-term services and supports data is equally as important. So that's the department update at this time. Oh, and then I think there was one question you had asked, Mike, about the appointments. And Judy, I don't know if you had more specific updates. I know I have announced the opening for House Districts 2. Christina, yes, 2.
I don't have any specific information. Finding board members, and actually, that's probably not the right way to say it. The department does take a part in sort of casting a net to find people who are interested and to work with the governor's office to kind of point people in that direction. And once there is an appropriate slate of candidates for the governor to review, and Director Birch obviously works with the governor on that, they take action. So I guess kind of specifically what I know, we have one vacant position, and come July, we'll have a second vacant position, and we're just in the middle of the process. So I think that's mostly the case.
What's the time frame on renewals? I know a couple of us have put in the paperwork to renew. When do we hear on that?
Likely, I would say probably not before June, because your current terms don't end until the end of June. So I would think that those executive orders will be probably signed sometime in June, being effective July 1.
A couple of questions, and if you want to answer them later and bring back more information. One is I'm interested in the e-consult program that the state is experimenting with. I think we had a presentation a while back about this being used as a way to get increased access to specialty services, and I'm interested in the status of the implementation of that.
Okay.
And the second one was the grant that the state got to integrate behavioral health and physical health services, blanking, is it SIS?
The State Innovation Model, SIM.
SIM, I couldn't remember. I was going to say SIS, but SIS didn't sound right. SIM,
Yes.
It's something like
Yes.
that, right? I'm interested in I know that's housed in the governor's office, but it's being implemented in close partnership with healthcare policy and finance, and I'm really interested in what the long-term vision is for that and how we think care is going to get transformed, and maybe a presentation on that
Sure.
to the board at some point would be of interest.
Sure. So I can answer a couple of things.
Okay.
So the e-consult program is continuing to be developed through our Accountable Care Collaborative. But in partnership with that, it's also important to know that we recently launched ECHO Colorado, which is very exciting. There was a group of about 50 who came together and participated in the first consulting through the ECHO project. And ECHO, it's built on a model out of New Mexico that is really more around knowledge transfer from provider to provider than patient engagement through that process. So it's almost like you could imagine a virtual case conference for providers to come together. We're focusing on pain management to begin with because of a variety of reasons. One, there's prescription drug goals, reduction of overdose and misuse of prescription drugs in some of our state of health goals. It's an ongoing challenge in the state of Colorado. So the Project ECHO also may be another area of interest. It's been very exciting, and again, it's really designed to do some knowledge transfer so that local providers feel better equipped to manage patients that they're seeing within their practice, and hopefully then can build a repertoire of those skills. So e-consult is, though, more related to the actual sort of consulting around real-time patients, et cetera. So I can get Elizabeth Baskett from our innovation section has been working on both of those, so perhaps a joint presentation at the next board meeting about both of those would be useful.
That would be great.
Great. And then the last on the SIM grant, thanks for the question, Paul. The state innovation model is housed out of the governor, and Medicaid is a critical partner in that work. One of the core components, however, of the SIM grant is that it's multi-payer. So it is not just a Medicare payment reform mechanism. It's all payers in the state, aiming to have 80% of Coloradans have the access to integrated behavioral and physical health services. And so there's obviously going to be a range of ways that can occur in communities and based on sort of readiness of practices to move toward full integration and different types of integration. So I am attending a 4-day conference in Baltimore in 2 weeks with Vatsala Pathi, who is our director of our SIM program. So if I feel competent after that to provide the update, I can do that, or I'm sure Vatsala would also love to come or send one of her staff. She's beginning to build a staff to send one of her staff to also provide either a written update, as we did with the hospital provider fee, or a verbal update as part of our department update.
But it is clearly the intent that Medicaid providers would be encouraged to adopt this model of care as well.
Absolutely. So what we're trying to figure out how to leverage in partnership with SIM is our Accountable Care Collaborative structure. So as you know already, about 800,000 of those served by Medicaid are served through our managed fee-for-service structure. So the 7 regions with additional resources going to the regional collaborating organizations as well as primary care providers to get additional per member per month payments to provide sort of managed services, if you will. that program already has a series of key performance indicators that we've been driving toward and have reported to you. We're working very hard to align key performance indicators with those that have also been identified in SIM, so that we have the accountable care collaboratives headed in the same direction as some of the SIM projects. So that's the current work of trying to align those. There's a little bit of a leapfrogging that is also being worked out in that SIM is starting now. We're in the last 2 years of our current contracts with our RICO organizations, working toward a reprocurement that would begin, the contracts would begin on July 1st of 2017. So we're also taking into account where on the trajectory towards the goals of SIM and the goals of others to have better integration of our healthcare system, where might we be in the 2 years when the new contracts for the RICO entities would begin. So it's a little bit of dual thinking, and so both, I think, would indicate our high commitment at the department to support the rules of SIM. And it's fantastic work, and again, we know that many of the current BHO organizations and current RICO organizations are already partnering at the local level. I had the opportunity to visit Jefferson Center for Mental Health on a super utilizer project. So they're looking at those who are utilizing ER services based on the Bridges to Care project out of Aurora, which is based on the Camden, New Jersey hotspotting work. So that meeting at the Jefferson County Hotspotting Alliance has both the RICO, the Mental Health Center, the FQ, everyone is involved in that. So we know that those projects are already happening, and we're looking to see how can both the ongoing work of the Accountable Care Collaborative and the new technical assistance and work that's being done under SIM can all sort of move that in the same direction. There's a lot of moving parts.
There is a lot, and I think they're spotty. There are examples in different places where some of this work is going on very, very well.
Right.
And then there are areas where there are a lot of challenges, and spreading is going to be it's going to be a challenge.
Yeah, and we also, the last thing I'll say on this is the department was recently engaged along with our partners at CDHS and the SIM group, as well as one of our advocacy organizations, the Colorado Coalition for the Medically Underserved, where I used to be, are all part of a NASHP learning collaborative, so the National Association for State Health, National Academy of State Health Policy. And so we're all going to Philadelphia in May to learn about integrated care in the ambulatory setting. And so that's another way where we're trying to access federal or national technical assistance and, again, build stronger partnerships between the Department of Human Services, our department, and then our outside advocacy partners.
Great.
Thanks.
Sure.
Other questions from the board?
Yeah, this is Mary.
Hi, Mary.
And hi. So I think it was last month. I don't know. I had a note here. I follow up because on the school-based final report that was mentioned either last month or the month before. And I've been trying to access it, and I'm having trouble. So I was wondering if maybe you could just email that out to me, because I keep getting an error when I click on it trying to open it.
Off the website. I'll email that.
Okay, thanks.
Great, thank you. Any other questions? Otherwise, it's April in the Rockies, so we can all be optimistic about our Colorado Rockies. And,
opening day is today.
Opening day and
Win on the
Donna's
road.
in the right
play
color.
ball and all
They
those
got
good things.
3-0.
Yeah, how about that? So we're adjourned. Go watch baseball.
Terrific.
Want to help yourselves take a week?
Are you going to the game?
No, I should have planned a heck of a lot.